Welcome. If you're a healthcare professional, we are getting straight to it. We're focusing on the single most time-critical skill in trauma management.
Exactly. This is a high-stakes refresh. We're talking about absolute mastery over controlling massive external hemorrhage with an extremity tourniquet.
Seconds to save a life. These are the steps.
These are the steps that matter.
Okay, so let's start with the framework. We all know the primary survey, the classic ABCDE, but that's changed, hasn't it?
It has. Now, we really teach xABCDE. The control of massive hemorrhage is prioritized first. It's the X step.
And why is that? Why the shift to putting bleeding first?
Because massive hemorrhage, what we call exsanguinating hemorrhage, is the fastest way a trauma patient dies.
The most immediate threat.
By far. If you don't control that bleed, frankly, nothing else you do for their airway or breathing is going to matter. This is life-saving, and it takes, literally seconds to start.
Speed is everything. So that brings us to indications. When do we skip direct pressure and go straight for the tourniquet?
Well, the classic indication is still any extremity bleeding that you can't control quickly with those basic steps. But, we need to be much more aggressive.
So what are the absolute non-negotiable triggers, the things you see that mean you apply one immediately?
There are two big ones. First, if you can actually see spurting arterial hemorrhage, that's a no-brainer.
No waiting.
No waiting.
Yeah.
And second, a complete or a near-complete traumatic amputation. Those are tourniquet injuries from the get-go.
And the data on this is clear, right? Earlier is better.
It's crystal clear. All the retrospective studies show that early placement for massive hemorrhage is linked to much, much better patient outcomes. If you're even debating it, the answer is probably yes.
Okay, let's get into the mechanics. The physical application. We used to hear high and tight. That's not the best practice anymore, is it?
No, we need to be more precise. The current standard is 2 to 3 inches, so that's about 5 to 8 centimeters, proximal to the bleeding site.
And why that specific distance?
It's all about compression efficiency. You have to avoid placing the device directly over a joint, like an elbow or a knee.
It just won't compress effectively there.
Exactly. It can't. You want to be on a part of the limb where you can compress the artery against a single solid bone. That's where you get maximal effect.
So 2 to 3 inches up, avoiding joints. And what about clothing?
Look, in the field, you do what you have to do. But if you're in a controlled setting, in a facility, the ideal is to apply it directly onto the skin.
Right.
It just removes any variable, any bunching of material that could stop you from getting adequate pressure.
No, the tightening, this is where people can hesitate. What's the mechanical goal we're trying to achieve?
You must, and I mean must, overcome the patient's systolic blood pressure. The constriction has to be greater than the force of the heart pumping blood out.
So if you're below their systolic pressure...
You failed. The intervention is not working.
And that, I imagine, is incredibly painful for the patient.
It is. It is intensely painful. And that pain is actually a sign that you're likely getting it tight enough. You have to tell the patient this is necessary. You don't stop tightening because of pain.
You stop when the bleeding stops.
You stop when the bleeding stops.
This is maybe the most important part. How do we know it's working? What are the two definitive checks for an effective application?
The first one is simple. It's visual. The bleeding has to cease completely. Not slow down. Stop.
No dripping, no oozing.
Nothing. And the second check, this one is the confirmation. The distal pulse must be gone. Not weak, but non-palpable.
And if you can still feel a pulse distal to the device...
Then you have not achieved arterial occlusion. The tourniquet has failed its one job.
Okay, let's talk about that failure. We've put one on, we've tightened it, but the bleeding continues. What's the immediate next step?
Do not waste time twisting the one you have more. If it's not working, it's not working. You immediately place a second tourniquet.
And where does that second one go?
It goes 2 to 3 inches proximal to the first one. You stack them. Move up the limb until the hemorrhage is controlled.
This brings us to a really critical danger. What happens if it's not tight enough? Why is a loose tourniquet so bad?
This is the dreaded venous tourniquet scenario. It's one of the most dangerous mistakes you can make.
Explain that. What's happening physiologically?
So, if the device isn't tight enough to stop the high-pressure arteries, it will still be tight enough to collapse the low-pressure veins.
So arterial blood is still pumping into the limb.
But the venous blood can't get out. It's trapped. So you're actively causing the limb to fill up with blood, which dramatically increases the swelling and the pressure.
And that actually makes the bleeding from the wound worse.
So much worse. You'll see the limb get swollen and cyanotic, dark blue, very quickly. It's a cascading failure caused by the intervention itself.
Is there a quick field test for this?
A simple one is if you can easily slip a finger between the band and the skin, it is almost certainly not tight enough. But the real clinical sign, the one that matters, is the loss of that distal pulse.
Okay, so we have it on, it's effective. Now, documentation. This is life-saving but also tissue-destroying. What do we have to record?
Time. The exact time of application is absolutely mandatory. Time is tissue. Every provider who takes over care for that patient needs to know exactly how long that tourniquet has been on.
And where's the best place to write that time?
Directly on the tourniquet itself. Most of them have a white strap specifically for this. Use a permanent marker. Make it impossible to miss.
Let's talk about the clock. When do we think about taking it off or conversion, and what are the critical time limits?
Conversion should really be attempted during the secondary survey after the patient is stabilized. You need a controlled environment to properly assess the wound.
What's the general safety window for duration?
Generally, less than 2 hours. If a tourniquet has been on for under 2 hours, the risk of serious permanent complications is relatively low. That 2-hour mark is the first major checkpoint.
And after 2 hours?
After 2 hours, the risk of ischemic injury and limb loss starts to climb dramatically. Once you get past 6 hours, amputation is almost a certainty. The tissue is just not viable anymore.
Those are stark numbers. Is there any situation where, no matter how long it's been on, we absolutely do not attempt to convert it?
Yes, you never ever attempt conversion on a patient who is in shock. If they're hemodynamically unstable, that tourniquet stays on, period. Removing it could release toxins and cause their pressure to crash.
So beyond just losing the limb, what are the other big physiological risks of leaving it on for too long?
Well, you have significant risk of permanent nerve damage, so neuropathies, and also rhabdomyolysis.
Muscle breakdown.
Right. The muscle tissue breaks down, releasing contents that are toxic to the kidneys. It's a life or limb trade-off, but the complications are severe.
So, to bring this all together for the clinician at the bedside or in the field, the non-negotiable goal has to be complete arterial occlusion.
Complete occlusion.
And that is confirmed only by the absence of a distal pulse. It is a temporary, high-pressure, life-saving device.
Absolutely. And one final thought. We need to be ready for what happens when we do take it off. The conversion itself can be dangerous.
How so?
Especially after it's been on for a while. When you release it, the reperfusion can cause systemic effects, things like a sudden drop in blood pressure, profound acidosis. You have to monitor that patient incredibly closely, even after the device is off. The danger isn't over just because the tourniquet is loosened.
Check the pulse, write the time, and watch the clock. Thank you for joining us for this essential update.